Well, good morning, and can I welcome everyone to this, the 15th meeting of the Public Audit Committee in 2025. We've received apologies this morning from Stuart McMillan, and so can I welcome Stephanie Callaghan, who is substituting for Stuart and attending virtually for this, her first meeting of the Public Audit Committee. And because it's your first meeting, Stephanie, can I ask you to declare any relevant interests? Stephanie, can you hear me? Do you have any relevant interest to declare? Sorry, you're on silent. Could you speak?
Okay, I'm unmuted now, I believe, Richard.
Yes. Do you have any relevant interest to declare?
Yeah, just for the record, I was a South Lanarkshire Council councillor until 2022.
Okay, right. Thanks very much. What I'm going to do now is move to agenda item 2, which is for members of the committee to consider whether or not to take this morning's agenda items 4, 5 and 6 in private. Are we all agreed? We are agreed. Thank you. And agenda item 3 is consideration of the report by the Auditor General into general practice progress since the 2018 General Medical Services contract. And I'm very pleased to welcome to the committee this morning the Auditor General, Stephen Boyle. Good morning. Alongside the Auditor General this morning is Carol Calder, who is an Audit Director at Audit Scotland. Joining us online is Eva Thomas-Tudo, who is an Audit Manager at Audit Scotland. And again, in the committee room, I'm very pleased to welcome Fiona Lees, who is a Senior Auditor at Audit Scotland. You're all very welcome. We've got quite a number of questions to put to you this morning on the report that you've produced. Before we get to those questions, Auditor General, can I invite you to give us a short opening presentation?
Well, many thanks indeed, Convener. Good morning to you and the committee. As you mentioned, Convener, I'm bringing the committee my report on general practice, which considered the progress that's been made implementing the 2018 General Medical Services contract. My report highlights that since 2018, pressure on general practice has increased. Reasons for this include a growing and ageing population, enduring health inequalities, together with longer waits for hospital care. Alongside this, the number of estimated whole-time equivalent GPs has fallen, and spending directly on general practices has now started to decrease in real terms as a proportion of overall NHS spending. People are reporting that they're now finding it more difficult to access healthcare and are less satisfied with the care that they are being provided with at their general practice. The 2018 GMS contract aimed to address financial pressures, growing workloads and improving patients' access to care. However, 7 years on, several commitments have not been fully implemented, and there is now uncertainty about the strategic direction for general practice in Scotland. Challenges remain with rolling out what's known as multidisciplinary teams across the country, and some proposed changes to the way that general practices are funded have still to be agreed. COVID-19 impacted plans, but there remains a lack of clarity about whether and when the remaining contract commitments will be fully implemented, how much this will cost, or whether the changes introduced represent value for money or have improved patient care. Convener, I note last week's programme for government commitments for an extra 100,000 GP appointments by the end of this year, focusing on preventative measures. But the Scottish Government still needs to clarify its plans for general practice and set out the actions, timescales and costs to deliver it. My report makes a number of recommendations to the Scottish Government, but implementing many of them will require the support of GPs and collaborative working across the health and social care sector. Convener, as ever, we'll do our utmost to answer the committee's questions this morning on the report. Thank you.
Thank you very much indeed for that outline. I'm going to go straight away to Graham Simpson, who's going to open up on the questions that we've got. Graham.
Thanks very much, Convener, and good morning, Auditor General and your team. I have to say, this was a damning report, but it probably told those of us who occasionally have to use GPs, nothing we didn't know already. Services are strained. It's often difficult for people to get a GP appointment. And if we can go back to, you mentioned the programme for government and the announcement of those 100,000 appointments for things like high blood pressure, high cholesterol, etc. That was in the context of the First Minister saying that he wanted to end the so-called 8 a.m. rush, which is basically a booking system that many GPs use where you have to phone up at 8 a.m. And that's it. You have to phone up at 8 a.m. So if you can't phone up at 8 a.m., quite often you're snookered. Now, given that's his ambition, if we were to turn to the letter from Dr. Ian Morrison, which I presume you've seen from the BMA, and he says some very strong things. He says, we've called on the Scottish Government to urgently address the shocking situation that general practice is in and invest directly in GP practices. The funding practices receive for every patient has been eroded year after year against inflation since 2008. In all, eroded funding streams and new cost pressures have created a shortfall in practice funding of 22.8%, and some 290 million will be required to close that gap and deliver full funding restoration. So Dr. Morrison presumably knows what he's talking about. He represents GPs. So given the situation you've outlined in your report and these damning comments from Dr. Morrison, does the First Minister have any chance of achieving his aims?
So there's a lot in your question, and try and kind of address all of that through our responses, Mr. Simpson. As ever, if I omit something, please remind me, and I'll try and cover all the points you make. I think perhaps start with the detail of the announcements in the programme for government clearly came after the publication of our report. But I think perhaps firstly signpost the committee to paragraph 30 in the report, which identifies the Scottish Government's announcement in November of last year of additional recurring funding of £13.6 million to ease pressures, together with a £10.5 million funding in 25-26 to target general practice. And much of the discussion the committee will be familiar with about earlier intervention, preventative spending, and this seems to be the thrust of the £100,000 additional appointments by the end of this year. In and of itself, that would be a welcome contribution. But I think maybe just by way of context, it's helpful for the committee. What does that mean in the kind of relative scale of interactions that take place at GP across the country? And Public Health Scotland data discloses. So if we take March 2025, maybe not an average month, still in winter pressures, but indicative overall of the scale, it's helpful. So there are 2.9 million direct encounters in GPs in the month of March. So if you extrapolate that across the full year, over 30 million direct encounters take place every single year. So 100,000, of course, that's welcome. But that is also going to be, and more detail, this is still necessary. So we don't have all of the precise information about what the 100,000 will be used for. But I think it's suggested, Mr. Simpson, that it will be along the lines of, as I say, more preventative measures such as cardiology, assessments, general health improvements, some of those preventative interventions. I guess what I'm not yet clear, and I'm going to bring Eva Thomas-Tudo in a second, who's done some of the analysis of this, if that's actually going to ease some of the pressures that have been spoken about in the system and that Dr. Morrison outlines too. So I think for us, we've kind of thought carefully, of course, going through our report and the evidence that we considered in arriving at our judgments and recommendations, that there is pressure in the system. The GMS contract that was designed to address these pressures hasn't yet been implemented in full. And that's led us to the recommendations we make in today's report on pages 6 and 7. There still remains a need for a clear delivery plan to implement the refreshed vision for primary care, together with clarity on what the next steps are to implement the outstanding parts of this contract. I'll perhaps come back to your access point in a second, if I may, but if you're content, I'll maybe bring Eva in just to say a bit more about our assessment of the programme for government announcements, first of all. Eva.
Thank you, Auditor General. Yes, I'm happy to provide a bit more information. So our understanding is that this announcement provides more detail, as the Auditor General highlighted, of that £10.5 million that was announced as part of the 25-26 budget. The Scottish Government has now kind of provided that information that it's intended to provide 100,000 extra appointments in areas of, sort of preventative work for cardiovascular disease. So the concerns, I guess, that we've got around it is about the capacity that general practice has to deliver that. So the Royal College of General Practitioners and the BMA have both come out to say that they're not clear, I guess, on how much capacity general practice has to deliver that. And also, given that it's intended to provide an additional sort of enhanced service for cardiovascular disease prevention, it's not clear whether that's going to have a significant impact on that 8 a.m. rush access to appointments, because it's actually providing services that weren't necessarily happening before.
Thank you. I think just perhaps to address, and I'm happy to take any follow-up questions, of course, Mr. Simpson.
Okay. Yeah.
Sorry,
Sorry, have you?
No,
finished?
I think I'm sure we'll cover more of what I was going to say in a moment, but I'm happy to pause.
Okay. It struck me that if you want to end this 8 a.m. rush, and you know, it's not just the First Minister saying he wants to do that. Other political leaders have said the same. It strikes me that you need to know how many GP practices actually operate that booking system in order to start to tackle it. But we don't know that, do we?
One of the features in today's report, and again a theme that's familiar to this committee, is about the adequacy and quality of data in primary care health services in Scotland. Fiona's looked at much of this in some of the work that we did, so again I'll bring Fiona in a moment just to develop our position on this. There are many plans and work streams in progress across NHS boards in Scotland, Public Health Scotland, NHS Education for Scotland, National Services Scotland, all working to improve the quality of data that allows informed strategic decisions to be made about how primary care services will be delivered. But we have a fundamental remaining issue that there is not enough good quality data on how we're talking, general practice today is being delivered that allows that evaluation, monitoring, and as I mentioned in my opening remarks, Mr. Simpson, value for money, which is a core part of our responsibilities and interest of this committee. It's difficult to make these judgments when we have data, not just about access in terms of the morning rush, but also how patients' numbers, the number of GPs, which I'm sure we'll talk about today. There are survey data, there is estimated data, but fundamentally at its heart, not yet good quality, sustained empirical information that allows effective decision-making and monitoring to take place. But again, I'll probably bring Fiona in to can elaborate and say how we approach that as part of our audit.
Thanks, Auditor General. So, yeah, to answer your question, no, we don't know exactly how many practices allow online booking. We know that some do it through their websites or through external systems such as patient access, but we don't have central data that would tell us how many allow those patients to book appointments online.
And in fact, they're not required to supply that data.
It's not actually a question that we asked, that one, so I don't think I could say that for sure. So, but as far as we're aware, there's no centrally held list that would tell you or have that information. I'm sure if you went around all the practices and asked them, they could provide that information, but we didn't do that as part of this audit.
The one thing I would add is, as I mentioned, some of the work that the national boards are undertaking. There are plans, there are aspirations for greater consistency and better health data. There's plans for a national GP IT system by next year, and as I'm sure you've seen in the report, that some of that is encountering some challenges with the supplier of the system having gone into administration. So there are delays therein to make that a viable product. There's a new web app or application to better capture some of the workforce data. But I think these are symptomatic, Mr Simpson, of really the contrast that is so stark of how data is used and captured in primary care compared to an extensive volume of data that exists in hospital or acute services across NHS Scotland. And I know the committee is familiar with this, having taken evidence from Public Health Scotland on that point.
I'll come back to data, but if I can just go back to the pressures that GPs are under, and that's really due to a lack of GPs and a large number of patients. In fact, in paragraph 13, you say there are more patients than there are people in the country, which is quite staggering. But I was struck by paragraph 15 in your report, which shows the difference across the country. The number of patients per whole-time equivalent GP varies widely, it says, from 721 in NHS Orkney to 2,373 in NHS Lanarkshire. Now, that's the area that myself and the convener and Stephanie Callahan, indeed, represent. And myself and the convener were at a briefing last week at North Lanarkshire Council, and health was a big feature of that briefing. And although North Lanarkshire is doing well in some respects, in health terms, people are basically struggling to get health care. And actually this figure shows why. Because we basically don't have enough medical practitioners, GPs and others. So that is a challenge in some parts of the country for the actual overall health of the population, is it not?
Let me address those points that you make. The first one, you quite rightly draw attention in paragraph 13 to the difference between the number of people registered with a GP and the overall Scottish population. That perhaps that feels like a very curious anomaly that exists. The Scottish Government recognise this, and as we set out in the report, have commissioned a short life working group to better understand why this is. Again, as we've talked about already this morning, data is part of the reason for this, but I think it's also symptomatic of some of the more transient population that can exist in the country. Student population is often cited as part of the reason why that. If people register, then leave the country but don't deregister their records. So I think at the very least some data cleansing required around part of that. On paragraph 15, and I might also just touch on for reference paragraph 62 in a moment, which potentially links, I think, to the points that you're making about the regional variation that exists in terms of patients per practice in different parts of the country. I think some of the island boards, perhaps not surprising that they'll have the lowest, just given the geographies that exist relative to population centres on Scotland's 3 island boards. NHS Lanarkshire, and I'm not drawing a direct correlation between this point, Mr Simpson, in terms of patient satisfaction, but again, it is noteworthy that paragraph 62, and as we set it, I suppose, also in Exhibit 5 on page 26, drawn again from a survey for the Health and Care Experience Survey, is that people are less satisfied about the care being provided by their general practice in 23-24 than they were 6 years previously. And in NHS Lanarkshire, as we know at the final bullet point on para 62, is the least satisfied part of Scotland with their general practice. As I've said before, I do caveat that I'm not drawing a direct correlation between GP number of patients registered by GP with the satisfaction levels. But I did think it was noteworthy to see the fall in satisfaction levels in NHS Lanarkshire.
Yeah, I did note that. I have to say, as someone who lives in Lanarkshire, I'm actually happy with my current GP, but only after I moved GPs because I couldn't get an appointment with the previous one. So I've gone to a GP practice which doesn't operate that 8 a.m. system, but not everyone can do that. That the ability to switch is not widely known, and it's not always that easy. But I want to move on to something else if I can, because you mentioned the spending on the 6 priority areas. Is there a reason why the Scottish Government doesn't publish spending on the 6 priority areas? Because that limits transparency and public scrutiny. Have you asked them about that?
So I'll bring the team in actually just to kind of set out some of the engagement that we had. Carol can talk to this in a moment, but we share your concern if inferring from your question about the need for better disclosure of spend on the priority areas. And Carol can touch on this in a moment. Because of inevitably some of the progress has been interrupted. I think we've seen that, of course, during COVID, that progress in the rollout of the priority areas didn't progress as quickly as planned. We've also subsequently seen a focusing of aspects of the 6 priorities to better deliver progress and implementation. But we do think it's a gap, that there needs to be clearer public reporting of impact of spend. Again, goes back to kind of the core of our responsibilities to form an assessment of whether value for money is being delivered from these amounts of public spending. But I'll bring Carol in a moment.
Yeah, what we found as part of the audit is there is a lack of transparency around the spend and the impact around those 6 priorities. We don't know what full implementation of those priorities might look like and what costs that would be associated with that. But Health and Social Care Partnerships have estimated that there's a £125 million shortfall to cover the 3 prioritised areas within the 6 and to maintain the other 3 areas at current levels. What we've noted is that the work that has been done to develop these multidisciplinary teams varies across Scotland, but that variation is not directed or targeted at most need. So there's a lack of transparency and insufficient information on spend and impact. And what we said in the recommendation is we know that there is a new plan for primary care reform that's due this summer, but we would like to see a clear delivery plan and vision for general practice primary care. And part of that delivery plan, we want to see, as the Auditor General's already noted, clear actions and timescales that are costed. But we'd also want to see clarity on the current commitments in the General Medical Services contract, whether or when they will be delivered, what that might look like, how much that will cost and what funding is available, but also what data will be required for them to monitor and report publicly on the impact and the total spend.
Okay, thank you for that. The report, it says that the government's most recent annual progress report highlights that 3,540 whole-time equivalent of the 4,925 whole-time equivalent staff working across the 6 priority services. That's at March 2024. were funded by the Primary Care Improvement Fund. So do we know where the other 1,300 were funded from?
I'll ask colleagues to come in on this. Actually, thanks, Fiona. We want to pick this up. Just to perhaps to you're referring, I think, to Exhibit 4. Am I right, Mr. Simpson?
Yeah.
In the report that kind of sets out the relativity of the primary care improvement fund together with some of the direct spending on general practice. Multidisciplinary teams, of course, are also run by health boards, and I think this was one of the objectives of the contract, to better balance the wider contribution that health boards, together with the independent contractor model that we have for GPs, will make that contribution. But the relative use of the primary care improvement fund compared to direct spend, I'll pass to Fiona to set out.
Yeah, to answer your question, no, we don't know how the rest of that is funded. We know the money is coming through boards, but I know that Eva looked at this in more detail, so she might be able to provide more details, but no, we don't know where that additional funding comes from or exactly how much it is. So Eva, could you add to that?
Yes, happy to. Thank you. As others have said, there is a lack of transparency about the full amount that is spent on those 6 priority services. HSCPs are asked to provide spending through the Primary Care Improvement Fund annually, at least, to the Scottish Government. However, there is spending, as you've noted, on potentially quite a lot of spending outside of the Primary Care Improvement Fund, amounting to that sort of 1,300 whole-time equivalent staff. That is likely to come from a range of other services, so either core HSCP funds, there are specific vaccination funds as well that contribute towards that, and also specific pots of money for things like mental health. For instance, Action 15 funding goes towards that as well. I think that the problem is that there isn't anywhere that information is collated or collected consistently across Scotland. So it's very difficult to get an overall picture of how much is spent on those 6 priority services across all of those different service areas.
Well, I've got to say this is all very concerning indeed. This lack of transparency, and actually it's a feature of your report. In fact, there's we'll come to paragraph 100, where you say the Scottish Government has not been transparent about the investment in sustainability loans. We're moving on to a different issue, of course, and has made a misleading announcement about the uptake of the loans. It's quite an accusation to accuse the government of being misleading. What lies behind that?
I'll ask Carol to set out the detail of paragraph 100 and the reason we make such a judgment, Mr. Simpson, about the request for funding from practices, whether it was loans or eventual board ownership. Maybe if I step back for a second, I think the purpose of including premises as part of the GMS contract was again part of the sustainability that was sought from the 2018 contract, that essentially would allow general practice to focus on providing health services rather than the additional responsibility and focus required to own, manage properties across the country. I think what you're seeing, and it's maybe symptomatic, Carol can set this out, is that the implementation of this part of the contract has felt and looks very challenging for the NHS and health boards. Quite long timescales involved, into the 2030s and 40s for some of it. Question mark about whether there's sufficient funding, and then also a real interruption factor, because much of the funding had assumed to come from the committee may be familiar with financial transactions, which was part of the funding stream that the Scottish Government received from the UK Government. Financial transactions, though, are no longer part of funding to anything like the extent that they were. So again, a much more challenging fiscal context with which the Scottish Government and the health boards are operating in to take on buildings and loans and premises. That context is relevant, but again, I think it is not a legitimate reason not to be transparent about spending or progress against premises. And again, Carol can share with that with the committee.
So yeah, originally £30 million was committed between 2018 and 2021 for sustainability loans for those GP practices that applied for those loans. They would get 20% over a course of 5 years. So in 2019, that 30 million was increased to 50 million commitment. But what we know is that by 2020, there had been no loans that had been paid out. What we know now is a total of 63 loans have been paid out to the equivalent of around about £15 million over 5 years. But as the Auditor General said, that funding stream that came from the UK government had been reducing in recent years, and in the 24-25 budget, there was no financial transactions capital available in the health portfolio to go forward. So there is uncertainty, and we are advised that Scottish Government is reviewing their options for this scheme. Coming back to the statement that we've said was misleading, in 2019, the Scottish Government said that 172 loans had been successfully applied for, but actually it was 172 loans, 172 applications that expressed interest in the loans had been received, and at that point no loans had been issued. So that's why we've said that is misleading. What we should also, maybe in terms of scale and context, is that so 63 loans have been issued, but in 2019 a survey indicated that there are around about just under 400 GP practices that are owned by the practice. So 63 out of 400 is roughly 16% of those practices that are owned that have received a loan. But at the moment, there is uncertainty about where the funding is coming from. Individual health boards were required to produce infrastructure plans at the beginning of this year. Too late for this audit, so we didn't see those plans. But we would expect that those plans would include not only the numbers of GP practices and leases that the board now owns, but the condition and the maintenance of those premises. But we'd also anticipate that those plans should include the plans for the individual boards on taking on more leases and premises and providing premises for general practice. So we'd like to see what individual boards are planning to do locally for their local practices.
Sorry, I've got sort of one final question. I know I've taken up a lot of time, but there's a lot to cover. So, given the state of finances of health boards, which we've covered in this committee before, it strikes me that why would they actually want to take on the responsibility of owning the buildings that GPs work from?
So there was funding available and committed back in 2018. What we found in terms of the boards taking on the leases of those premises that are rented rather than owned is that there was no funding for that. It was intended to be a cost-neutral exercise. And the, let me get the name of this group, I stumble over this every time. The NSS Primary Care Premises Group have indicated that some boards are reluctant to pick up leases where there are maintenance costs, because those maintenance costs were not factored into that cost-neutral calculation. So that could be one of the reasons why boards are reluctant to pick up the outstanding maintenance costs. There was a 2018 national survey of maintenance, and at that point there was estimated around about £60 million maintenance backlog in general practices. There's not been any surveys since, and there is no specific oversight for how fit for purpose those premises are.
Just to add, Mr Simpson, I think just to direct the committee to the recommendations on page 7, or the final recommendation that we make in the report within the next 12 months, really for the Scottish Government to set out how it plans to take forward this part of the contract in respect of the role that NHS Scotland boards will play in terms of the existing infrastructure and any infrastructure planning. That there are many things in today's report that are important, but I get this and one that feels quite fundamental to access and where services will be provided.
Okay, thanks, Convener.
Yeah, thank you. And I mean, on that last point, it doesn't feel as though there is a kind of whole system approach, because we regularly, as a public audit committee, have the Scottish Government and representatives from health boards saying that they've been asked to make recurring and non-recurring savings of 5% every year. And often the non-recurring savings we get into are around things like disposal of property or disposal of land. So unless this is properly resourced, it's just simply not going to work, is it?
Yeah, so there's undoubtedly work to be done. And I think what's peppered through today's report is that the dynamic is different. So this is an independent contractor model, and that is always going to be at the heart of the reach of government, the role of boards in respect of what was a shared contract agreed between BMA, Scotland, Scottish Government, boards, but there are gaps in implementation very clearly, and that I think are again reflected through all the recommendations about how this service, this vision for the provision of general practice will be delivered, and really the need for now a very clear clarity together with a delivery plan to take forward to the implementation.
Yeah, I mean, and going back to that kind of whole system perspective on it, one of the issues, presumably, which GPs are grappling with are the waiting times in secondary care. And so if people are on long waiting lists to get selective surgery or other procedures, then presumably that is leading to an increase in demand on GP services to infill for some of that. So, I mean, do you have a view about the necessity of tackling not just the general medical services side of that, but the need to tackle what's going on in secondary care as well? Presumably you can't have success in one without achieving success in the other.
No, you're quite right. This is a whole system factor. Today's report only looks at the progress in implementing the GMS contract from 2018, but as has been mentioned by Mr Simpson, some of the recurring whole system features we've touched on in our NHS reporting in the round, and again we'll return to that later this year through our overview of the NHS. But maybe just, Convener, on the pressures point that you make, what we look to do really, Exhibit 3 on today's report is to set out the nature of some of the pressures on general practice, and the very last point on that table is about the impact on general practice of more people waiting for treatment in Scotland's hospitals, and how that has shifted quite fundamentally, just by way of the statistic we report from September last year, with 38,000 or just over people waiting for inpatient or day case treatment compared to 1,600 before the pandemic. And that inevitably has a bearing on the time, the need for general practice to support people waiting for treatment in hospitals. But as I say, just one of the 6 themes of pressure that we sought to identify on that part of the report.
Okay, and again, you've mentioned it a couple of times in the last few minutes, which is about vision and strategic direction. And in, I think, key message number 2 in your report, you begin that by saying there is uncertainty about the strategic direction of general practice. I mean, could you maybe elaborate a little bit on that? What are the missing ingredients there? Is it about transparency, or does there simply not exist a vision or a strategic direction for general practice?
So I think, again, I'll bring colleagues in a moment. I think what we sought to do really is a kind of stock take of the implementation of the contract in the report. And a sense that's come through from the evidence before us that we're not yet clear of the route through to fully implement the 2018 contract. We've touched on a couple of those themes already in terms of data, premises. I'm sure we'll discuss further as we go over the course of the morning, but access and capacity to implement the contract, the number of GPs, the interrupted progress on rolling out multidisciplinary teams, whether there's sufficient funding in place, and the need for clarity around medium-term funding to implement the remainder of the contract. And that's where we get to, Convener, that so very clearly we have a contract. Not unreasonably as well, the pandemic interrupted progress, and that required a stock take to be made. But it still led us back to the recommendation that as part of the government's plans, and there are many plans and strategies underway, and we refer to many of them in today's report. But as ever, looking for how is that going to be implemented, and really the first recommendation that we make in today's report about the need for an absolutely clear delivery plan by the end of this year to support the implementation of a vision. So I think it's the weight of evidence that we've hopefully set out in today's report that casts doubt upon the achievability of the ambitions from the 2018 contract without that next step of clarity.
Okay, I'm going to bring Colin Beattie in shortly, but I've got one final question before I do that, which is about an area that we haven't discussed so far, but which is in your report, and which is, again, a feature that many people have come across in recent years, and that is the creation of GP clusters. And I don't know whether that's to try to address demand and supply and try and marry them up so it doesn't depend simply on solely being registered for one GP practice, but if you're part of a GP practice that facilitates you getting access to other GP practices in that cluster, presumably that's designed to improve levels of access to GP services. I mean, has that been fully funded? Is that been implemented? What's your audit assessment on how that's going?
Yeah, I'll bring Eva in a moment. Actually, has done some of the work on GP clusters, but effectively this was an intention to of both local area support across various GP centres, and as a mechanism to replace what had been known as the quality and outcomes framework, really with quality at its heart, so support and clarity around how well GP services were performing, Convener. But again, I think what we've seen in terms of clusters is not the pace of implementation that had been intended, nor a real sense of, again, there's the data and evidence to make a rounded assessment of progress or quality therein. So what looks like in the face of a welcome idea, still not having enough evidence to make a rounded judgment about whether this is working successfully either for GPs or for their patients. But again, if I can bring in Eva, I can set a bit more detail out of that for the committee.
Thank you, Auditor General. Happy to. So I think the Auditor General was right. The focus of GP clusters was more on quality rather than improving access. But the purpose of them was to kind of improve things, quality improvement and the way that the health and social care system worked. However, we say in the report that the implementation of clusters hasn't been kind of fully prioritised or fully funded. So research that has been carried out on progress with clusters has identified a number of barriers, such as a lack of time, a lack of support, a lack of meaningful data, and a lack of clarity about the purpose and the roles and the responsibilities of clusters. Some of the key roles for clusters have been fully funded by the Scottish Government. So every practice has a practice quality lead that is designed to kind of work together with other practice quality leads within their cluster. That has been funded for roughly 1 day a month, each practice quality lead, but that hasn't been uplifted since 2018, that figure. And also each cluster should have a cluster quality lead, and that hasn't been centrally funded. That is for local areas to to decide. So the issue with that is that there's now significant variation about the extent to which clusters have the kind of support and the funding that they need to work.
Okay. I mean, what seems to me to be emerging from the first 50 minutes of evidence that we've taken is that there are lots of announcements and lots of initiatives, but the implementation of them seems to be falling short. And as a consequence, as MSPs, we continue regularly to have correspondence with constituents who can't get access to their GP, and that, that remains an outstanding concern that I think all of us share.
I think that's a fair summary of the discussion we've had so far, Convener. And again, whilst I'm sure the committee will come on to talk about the funding investment that has been made in general practice, and we set much of that out in the report. But the gap, the implementation gap, or the evidence gap, is clear that there's insufficient evidence yet that this is making a difference. And whether that's access or survey data that patients are reporting that they're less satisfied with GP services, or that parts of the contract haven't been taken forward. I think what we sought to do today in the audit report is really just make an assessment of, based on all of the indicators, are that this remains a system under pressure.
Thank you. I'm going to now invite Colin Beattie to put some questions to you. Colin.
Thank you, Convener. General, I'd like to ask a question first about the transfer of services to NHS boards, which is a very key element in the GP mix. Now, in your audit, did you identify any evidence of where the workload still fell to general practice, despite the responsibility for providing the service to have moved to the local NHS board?
To an extent, Mr Beattie, yes. I think I'll maybe just refer the committee to paragraph 63 of the report. Hopefully this addresses the nature of your question in respect of multidisciplinary teams. And what we effectively mean is that those are support teams typically employed by the health board to deliver a range of services that had prior to this been under the auspices of GP practices themselves. I think, as we've touched on already, as you might expect, there is some regional variation in terms of where progress has or hasn't been implemented. But I think quite an interesting, again, a survey that Public Health Scotland undertook of GPs' views of how well multidisciplinary teams had been implemented. And again, some quite stark information about, as we've covered already, that the full intention or the number of multidisciplinary staff remains short of what had been anticipated. But we also report the GPs are noting that there's inconsistency in some of the work of multidisciplinary teams. Staff availability was again a barrier to effective planning, some variation in skills and experience. And then I thought particularly noteworthy that the last bullet point on paragraph 63, that of some GPs reporting that rather than being a benefit of implementation of multidisciplinary teams, that this had actually increased their workload by virtue of additional supervision and training requirements that they had to provide to multidisciplinary teams or the health board. So I think it's all sufficient to say that we feel that we're in the midpoint of the journey in terms of that transfer of resource and responsibility, but not yet clarity about whether this is working as intended.
The question of how effective this is has been getting asked now for several years. Is it all about money, or is it about will?
So, I mean, again, I don't think it's exclusively one or the other. I think, if I'm picking up rightly, is this about direction of travel for the implementation of the full contract? I think we need that clarity about the funding that's necessary, a medium-term financial plan, direction of travel to implement it. We talk about the delivery plan that's necessary around support teams, practice funding, the number of GPs, and when that will be implemented. So there there is a bit of a classic theme of an implementation gap or doubt as to where we currently sit.
Just another question, sort of in the same theme, about transitionary payments. Now, the Scottish Government made transitionary payments in 21, 22, 23. Is there any explanation as to why all practices receive transitionary payments, including those that had access to MDTs?
Yeah.
That doesn't seem right.
So I'll bring Eva in, actually, maybe can say a bit more detail about some of those aspects of the funding arrangements. Eva.
Thank you. So this was a decision that the Scottish Government made. The transitionary payments that were made in 21, 22 and 22, 23 were combined with winter support funding. And so the funding went to all practices rather than determining the extent to which MDTs were supporting those practices. And we've highlighted in that report that has meant that, that the support was kind of fairly inequitable. Since then, the Scottish Government hasn't provided national transitionary support, despite the fact that MDTs are not yet fully implemented. Instead, they have advised that local areas can arrange transitionary payments as appropriate. That does enable those local areas to provide support more equitably. They'll be able to kind of target that support where it's most needed based on kind of access to those MDTs. But it is expected to come out of their existing budgets. So if they have spent their full allocations on multidisciplinary teams, then they may not have the extra funding to provide those transitionary payments to those general practices that don't yet have sufficient MDT support.
That it doesn't seem a very fair system overall. Would you agree?
I think it's a question for the Scottish Government more than us about the allocation of funding, its interpretation of progress and implementation of the contract. I think what we're clear in the report is that the tailoring of the implementation of the contract is a decision for government. So one of the points we make on it is the extent to which health inequalities have or haven't been considered through the report. And there are a number of variables therein about how spending could be tailored but has chosen not to be. So I think I would kind of just to note that is the case, Mr Beattie, but I think it's more of a question for the Scottish Government about why it's chosen to do so.
Well, it's a question we can hold for them. I was going to talk to you about data. We always end up talking about data. You've talked about data already. Let's talk about data again. I can't recall now how long I've sat in this committee and it's been all about data, all about inability to validate where money is being spent because you simply don't have the data to know if the outcome is actually at the end of it. It's been raised by you, your predecessor. It's been raised by this committee and all its predecessors. Why is it that we continue constantly to come against this data gap? And how it's difficult to improve primary care when you don't have the basic information as to where you need to put the resources to get the outcome that you're looking for. So how do we deal with this? I mean, poor quality data just seems to be endemic.
So I absolutely agree with you. I think that, as we say in page 21, just, not that it in and of itself, but a lack of robust data makes it difficult for the Scottish Government to make informed decisions or evaluate progress. There are fundamentals here that need to be addressed. And while I think there is a recognition by the Scottish Government, so published their monitoring and evaluation strategy 6 years ago now, a 10-year approach to improving or assessing the impact of primary care reform in Scotland. And these are welcome things. I think we have to make a judgment about why is it taking the time that it's taking when we're seeing other factors in today's report, and as mentioned by GPs, patients, the BMA, that it's taking too long to address some of the concerns about data, that we don't have a rounded national picture of data to inform and monitor general practice arrangements. As mentioned to the convener, there of course is the dynamic of the independent contractor model here that is a factor to be overcome. We haven't audited this, but when we do make reference to some of the contrast in NHS GP practice in England, where there have been more recent steps to have a more rounded data picture. But I think I would characterise the contrast in Scotland, where these are more of local recording, local notes, rather than, as we see in GP centres in Scotland, there aren't people employed to record data. And last thing I would say about it, Mr. Beattie, that's quite a contrast with the investment that's been made in acute or NHS boards who have very detailed, robust data arrangements as a consequence of planned investment over many years, centres of excellence that exist around data. I don't think it's a welcome or sustainable position to have such a contrast between primary care and secondary care in Scotland.
Just looking at, obviously I was talking partly generally there, although with a focus on primary care, but looking at primary care, I'm aware of surgeries in my area that decline to provide data. And they decline for a number of reasons. Some of them say they're too busy. Others simply, we are independent contractors and this is not part of what we're contracted to do, is to provide this data. How do we deal with that? On that basis, you're never going to have the data that you need to be able to make the decisions you need.
So if you might want to touch on some of this, actually, we've looked at it through the audit, but I think if the case hasn't been made with GPs in Scotland about why robust data is important, or if they feel they haven't been funded or supported, or it's clear how they will best do that, I think there's an inevitability that there will be challenge and barriers to doing so. I think as we're already setting out in other parts of the report, the extent of pressure that exists in the system, the demands upon Scotland's GPs, if it's presented as such, more data is needed, but without that clarity about how they're going to be supported to provide that, it's perhaps not surprising that there is either incomplete data or if it's presented as on a voluntary requirement. These barriers have to be overcome, and I think it's, again, it's part of our own thinking and recommendations about this is so central for policy making and evaluation of primary care and all of the benefits that go with that. I think we make hopefully quite a clear statement in the report that preventative investment spend on primary care is good value for money. Keeping people well and out of hospital delivers better outcomes at lower cost, but getting good data is absolutely part of the route to sustaining that approach, Mr. Beattie. But again, if I may turn to Fiona to say a bit more.
Thank you, Auditor General. There's several reasons why things are a little bit more complicated in primary care than they are in secondary care. So, for one thing, there's not a lack of data per se. It's a lack of complete and consistent data at a national level. There's actually lots of data that's held by GPs in their clinical systems, but a lot of it is for direct patient care. So it's text-based, it's not coded, and it's not consistent, and it's not aimed at answering national outcomes, etc., in the way that in secondary care you have teams of people who are dedicated to collecting and validating and submitting that data. So there's also more complicated information governance arrangements because you're dealing with, nearly 900 private businesses. Also, not all of the data is held by GPs. Some of it is held by boards. So if a patient sees somebody in one of the multidisciplinary team members, then they might see them at a board, so that data would be held in a board's IT system, not the GP's IT system, and we know that these systems don't talk to each other very well. The other thing that you brought up that I think is important is that it does rely on GPs providing that data when they are asked, and a good example of that is the General Practice Workforce Survey, which is run once a year, and that's our best information that we have available to work out what whole-time equivalent GP numbers are. So at the moment, only about 85% of practices provide that information. I know that sounds quite high. That means that probably about 130 practices are not providing that information, and that means that we actually don't have really good, robust data around the number of GPs and GP capacity. So I think there is an important element in GPs being willing to provide that information to build national data sets.
Just coming back to what the Auditor General was talking about a few minutes ago, about persuading GPs of the need for good data. I mean, GPs are intelligent people. They must understand the reasons why data is necessary in order to measure the outcomes, to make sure that the resources are being put in the right place. And, you know, I can't conceive that they wouldn't appreciate that. But still, we have that difficulty.
So again, I'm quite sure GPs understand, the value of good data. As Fiona mentions, that we'll be using data within their practices to support the delivery of healthcare and the management of their businesses. I think it's probably perhaps drifting into speculation, and I'm quite sure GP representatives or GPs themselves will be able to give you a much more informed picture than I can. But I do think it's interesting just the incentivisation that was a feature of attempts to improve data in the NHS in England. We're going to be set some of that out in paragraph 49 of the report. This is a contractual model that exists here. If other parts of the system require it, then maybe incentivisation needs to be part of the plans to improve data. And I know that the Scottish Government are cited on these issues and have plans to take forward it. So we mentioned already about the national GP clinical system, again, which is at paragraph 50 of the report, that would look to go some way to addressing this, but unfortunately, as we've touched on, a bit interrupted by the financial position of the supplier. I think where I stand on it, Mr. Beattie, is that a way through these issues has to be found to have better quality data to support ultimately good use of public money for patient care.
Which really brings me to the last question on data, which was, are you satisfied with what the Scottish Government is doing in order to improve primary care data and providing the infrastructure to support it? Because it's got to be resolved.
It does have to be resolved. I don't think I could give you a definitive validation of that position at the moment. I think what we've seen is that this is a system, I think, as you started on this morning, that we feel like we've been talking about the need for better quality data in primary care in Scotland for too long. That the system has to move more quickly to arrive at a robust suite of data to inform decision-making and policy implementation and evaluation than we've got at the moment. So while we have strategies and recognition and plans, really got to see that being implemented at pace.
Just moving on to my last question, which is about GP headcount. In paragraph 81, you talk about there's not enough information about the number of hours worked by GPs, which seems extraordinary. Apparently, the there's evidence that the average number of sessions worked by GPs was measured at 6.4 sessions in March 2024, and it's decreased to 6.2, which doesn't sound a huge decrease, but multiply it up across the country and it's perhaps a lot more significant. So, given the pressure GPs are under, why don't we know how many hours they're putting into the job? Why can't we evaluate that?
Yeah, I'll bring Fiona in again in a moment. I think it probably just builds on the discussion we've been having about this information, because as set out in paragraph 81, is drawn from a workforce survey rather than specific, reliable, validated system implemented information. But Fiona might want to say a bit more about that, and perhaps maybe return to how GP numbers are affecting ultimately what was about a desire for increased capacity within the system, improving access and throughput.
Yeah, yep. So that information is drawn from that general practice workforce survey that is run once a year. As was said already, it's estimated because not everybody responds to it, but they don't actually ask in that survey how many hours GPs are contracted to work. They ask how many sessions, and the problem with that is that sessions vary in length. They can be 4 hours in some places and 5 hours in others. So without that information, we can't properly assess how many hours they're working. Because anecdotally, a lot of GPs have said to me that they're working longer hours per session, but we can't quantify that because we don't have the data. So, but we believe for the next round of the survey for 2025, they are going to be looking at changing that. So instead of asking just for sessions, they're going to ask for the number of contracted hours, and that would certainly help give a better indication of what the whole time equivalent figure is. And if we could get the response rate up further and have more information from all practices, then we'd have much clearer information about what the capacity of GPs actually is in Scotland.
Indications that the GP surgeries are actually prepared to give out that information?
There hasn't been any indication that we came across in our audit.
Yeah, the number of hours people work. But I think it's important, there is a public perception that doctors are not putting a lot of hours in. And I don't believe that to be the case in most cases. But we need the evidence to be able to understand.
Yeah, I absolutely agree. We do need the evidence to be able to understand, and there's a difference between, again, how many hours you're contracted to work and how many hours you're actually working. And although we don't have national data about that, if we look at staff surveys that are run by the RCGP and the BMA, that would indicate that GPs are routinely working more than the hours that they're contracted to work. But again, without the evidence, I can't put a figure on that.
No, and that's back to the problem if you don't have the data to prove the point here. Do we have accurate figures for doctors that are part-time?
So,
to understand what part of the mix they are in terms of the full-time.
So again, that information would come from that survey that I've been talking about. So again, that's based on asking GPs the number of sessions they work per week. So if a full-time GP within the context of the survey works 8 or more sessions per week, so you can look at the data that's there and say, right, if you work less than 8, then you're part-time, and it chunks it up that way to tell you how many sessions they work. So that information is available. I don't have a breakdown with me today about exactly how many are part-time or work fewer than 8 sessions a week, but that information is available in the survey, estimated though, based on, and with all the caveats around that data that I mentioned before.
Estimated?
Yeah.
When is you said there's another survey, there is a survey going out?
Yeah, it's usually run once per year. Normally they collect the data as at March of a year, so, and then by the end of this year we would have that information. So
this year that survey will actually be changed to ensure that the more robust data is being collected in terms of...
My understanding is,
yeah.
yes, they're going to change it, but that's perhaps something you could ask Scottish Government to confirm.
Okay. Thank you. Thanks, Commissioner.
Okay, thank you very much. I'm going to bring Stephanie Callaghan in, but I've got two quick questions to put to you. Well, I think the quick questions before we get to Stephanie. The first one is, and it goes back to data, which is that this committee has seen quite a few false dawns when it comes to data collection. And I went back to look to exactly 2 years ago, the 4th of May 2023, when the Director General for Health and Social Care, the Chief Executive of the National Health Service in Scotland, told this committee, and let me get this right, we have started the rollout of the next generation of information technology to general practices. We hope that that will help to improve ease of extraction of data from GP systems and that it will give us a chance to start with a clean slate on how data is coded. And that's what we've been speaking about this morning. I mean, and that's 2 years ago. So, I mean, do you get a sense, Auditor General, that there is a lack of urgency or there are legitimate reasons why the delay has been so extended in the way that it has?
I think what I would say, Convener, I accept that this is complicated, you know, and the rollout across what would we say, like you know, nearly 900 GP practices in Scotland with varying data or IT investment that's taken place, capability. So I understand that this would be a complex programme, and I don't in any way challenge the ambition of what the Director General set out. But I think it goes back to some of the discussion we've been having already today, that this is taking a long time. And it took a long time before that contribution 2 years ago. I think it's really for government to satisfy itself with its engagement with GPs and their representatives that they have a realistic, clear path to implement better data assumptions, standards, so that they can effectively manage either their investment from the government side and patient care in the round. So I don't want to say to you, Convener, that I've got confidence at the moment. I think there's a recognition and understanding of the issues and the complexity. But I think, as I've said a couple of times already this morning, this issue has to be overcome and at greater pace than has done so far.
Which leads to my second question, which is that what we're discussing this morning is described as a contract. Is it a woolly kind of social contract, voluntary arrangement, or is it a contract where parties are involved and there is some remedy to be sought? So it could be a remedy from the government to say, you, as part of the contract, promise to provide us with data which you're not doing, you're in breach of the contract. Or on the other side, the GPs might be saying, well, you promised to give us the resources to have multidisciplinary teams. You haven't done that. You promised to give resources into secondary care to stop the logjam falling back on us, and you haven't. You know, is there any? Is it a contract in the sense that people have got any access to a remedy if there is a breach of contract?
No.
Okay.
Is the answer to that? But that's not our understanding, and there is debate about this point, actually, about the appropriateness of continuing to refer to this as a contract. And indeed, we had some of the discussion during the course of our audit work. So remedy or recourse, or legal action, if it's not seen to be implemented, no, that's not our understanding. So I think, you know, whether you call it a plan, a commitment, or indeed a contract, I think it amounts to the same thing, that there was an expectation on both parties when this was agreed, our contract was agreed in 2018, that these would be the steps that would be taken, and you would know when it was implemented. 7 years later, I'm not sure we now know whether there's the clear path through to the implementation of this GMS contract. So I think there needs to be perhaps a reconvening of expectations. And again, if I may, Convener, that's really our fundamental recommendation. There's a clear delivery plan, shared assumption expectations about where general medical services in Scotland goes next.
Yeah. Okay, right. Thanks. That's a useful clarification. I'm now going to invite Stephanie Callaghan to put some questions to you. Stephanie, over to you.
Thank you very much, convener. So I'm quite interested in the progress around improving patient care. So we've already spoken a little this morning about how people are finding it more difficult to access healthcare at their general practice. And it's no surprise the Scottish Government have been commissioning some initiatives to help address this. One example being the Primary Care Access Programme that supports general practice teams to use data. Yes, we're talking data again, to identify areas for improvement and then look at improving an aspect of access over a short period of time. So I'm interested in whether you have any views on the steps that the Scottish Government is taking to help address concerns around people being able to access healthcare at their general practice. And I'd be really interested in any kind of positive examples of areas where progress has been made.
Very good morning, Ms Callaghan. Yeah, very happy to cover that, and I'll bring colleagues in, I think, to supplement kind of where I start as they wish. I think there's always a risk when you present a report like this that it's not necessarily reflecting that there are always some excellent examples of public service within some of the detail that can kind of risk getting squeezed out by an overall picture of one-off challenge. And I think that could be a feature of today's report. And so you mentioned kind of access and some of the examples. And what I might do is kind of bring colleagues in just to talk about one of the case studies that we've got in today's report about the evolution of kind of some of the services that can be offered in general practice, the role of community link workers in particular, just that centering of the role that general practice can play in improving people's lives. And I think there's some terrific examples in the report, but it's still perhaps a kind of wider feature maybe we haven't talked about today of I guess the impact that communication can have about people's perceptions, because we found in the report, again drawing on evidence, is that people aren't all that familiar with some of the changes in the GMS contract, not necessarily clear about the evolving role of either multidisciplinary teams or the changing focus that the work of practice managers or particularly GP receptionists can have, that they're now absolutely heart of these teams in GP centres, but people aren't always clear about what they do, a perception that can be an intrusive triage service rather than it's part of their job. So there's definitely more communication that's necessary with the public, but it shouldn't detract from the fact that some people are reporting that actually get an excellent service, happy with their GPs. So again, I'll maybe bring colleagues in if Fiona or Carol wants to start on that. Carol, I don't know if that's something you want to say a bit more on first of all.
I think there is a general misunderstanding with the public about the way that the nature that general practice is changing. And one of our recommendations is around making sure that there is better communication with the public about their expectations about how we all approach and receive care through our general practice, our local general practices. So I think there is, as the Auditor General mentioned, not necessarily the acceptance of those changes and the role of triage to get an appointment or to be directed to the right person, and also the roles of multidisciplinary teams. Maybe there is still a perception that we want a GP appointment. So I think there is work that needs to be done around that. But you're right, and the Auditor General is right in that this report focuses on the delivery of that contract. But we know that general practice play a critical part in our overall health service. They are the front door that everyone in this room as well as everyone outside of it, accesses health care in the first instance. That's our front door. So they play an enormous role in terms of referring people onto the right places, managing complex care in the community, being able to treat and diagnose common medical conditions. So it's a vital part, and I think we need to take the public with us in terms of how that we approach and access the general practice to access the wider health and care service.
Thank you. That's really helpful. And I suppose you to a degree kind of preempted my next question there. I would be interested as well in that case study that was mentioned as well, about hearing a bit more about that.
Carol, do you want to talk to that? Or?
Community link work?
Yes.
I think that might be Eva.
Thank you. Apologies. If I can bring Eva in, who can say a bit more about the vital role that community link workers play within their practice. But again, perhaps as a slight caveat, noting that there's often a degree of insecurity about their position and vulnerability to some of the financial pressures that are touched on in the system. But Eva.
Happy to come in on that, yes. So community link workers are one of those 6 priority services that are being rolled out across Scotland, and they're intended to kind of target non-medical support and things like support for sort of financial issues or other kind of social issues that you don't necessarily need clinical support for, but you go to get support. What we've said, as the Auditor General touched on there, is that a lot of the time community link workers are employed by third sector organisations with short-term funding and contracts, meaning that their jobs are kind of fairly insecure. The Scottish Government is carrying out a review of community link workers to determine the direction of travel with community link workers in future, and that's due to conclude next year. I guess some other aspects of access that you talked about in terms of good practice. We mentioned in the report as well about the primary care access programme that Health Improvement Scotland took on for a couple of years up till fairly recently, and that touched on kind of very specific aspects of access in practices, so improving things like access to appointments and that kind of thing, and streamlining some of those processes. What we would say is that it doesn't necessarily address the fundamental issues with access, such as workforce shortages and that kind of thing. So in terms of the impact that can have, it's fairly limited, but it does kind of streamline some of it makes processes as efficient as they can be in practices with the resources that they currently have. And that's now been kind of incorporated as part of a wider piece of work in the Faith Investment Programme, and it's what's known as an improvement collaborative, and so more practices are having access to similar kind of resources from Healthcare Improvement Scotland up until the end of this year.
Siva, certainly some good stuff there to hear as well, and of course we do need to value the third sector, and it'll be good to get that report out next year and have a look at it. I suppose kind of rolling back again to the issues around people understanding the changes that GP surgery as well, and I'm wondering what actions you feel are necessary for the Scottish Government to take to help the public understand how and why general practice is changing. You know, that rather than insisting on seeing a GP, waiting in a queue for that, and then being referred to the expert nurse anyway, that people are actually ending up waiting longer and waiting twice, but still insisting that's what happens. So I'm wondering what you think that we can do to tackle that.
I think, yeah, I absolutely agree. I think really paragraph 56, I think we mentioned that the Scottish Government initially ran a public awareness approach in March of 22 to kind of share with the public about some of the changing role, better understanding of the responsibilities of multidisciplinary teams and the role that receptionists will play in accessing care. I guess I'm left wondering though if that was enough. Clearly, I think the statistics suggest that either rerunning that campaign or finding additional or alternative ways of informing the public, and I'm sure that would have significant bearing on some of the satisfaction, because I think Carol's right. Whilst people might have had a traditional sense that when they contact their GP, it's the GP they want to speak to, I think people views change. They just want to be able to meet somebody or spoken to somebody who can help them with the problem that they've got. And satisfaction isn't necessarily dependent upon which member of the team that they were spoken to. So it's clear also, I think, that whether reflecting back to March 2022, that emerging from COVID and people's focus might have assumed that this was a legacy of COVID, the changing role of receptionists or multidisciplinary teams. So there are probably some misconceptions in the public that need to be addressed by health boards and the government to reset the evolving and changing role that general practice will have in providing services to patients. So again, I think this is a matter that government are familiar with, signposting people to different systems. The report also, for example, talks about the role that GPs' websites can play and that consistency. And there's work that NHS 24 have done on this. Again, I think it's an acceleration, Ms Callahan, about more consistency and more communication with the public to better inform them of how this new contract, and ultimately people don't really care about the contract, they just care about what service they can expect from their GP.
Yeah, absolutely, Stephen. I think you're bang on there. I suppose staying on that for a bit, because it is a really big, important topic as far as the people that we represent are concerned. And I suppose I'm a bit curious as well about, is it just about being the Scottish Government's role to explain to local people what's happening at GP practices? The fact that primary care is changing with those direct routes for allied health professionals. I'm wondering if perhaps there's a role for the Scottish General Practitioners Council to be kind of looking at that negative public narrative that there is around GPs and GP surgeries, and actually highlighting the strengths that AHPs bring to the table, and doing more work on this kind of thing locally and getting that information out and learning good practice with each other. Any thoughts you have around that area?
It's a fair point, especially given the nature of the contract being agreed with GPs and their representatives along with the government, and of course health boards as well. So there needs to be a shared ownership of providing clarity to the public on how these services are evolving. If that's not the case, and I guess some of the issues aren't addressed about ownership and clarity around the delivery of the contract, then inevitably will be a concern that communication is either inconsistent or at worst undermined. So some of the root issues that I think we set out in the report, along with the effective communication, would have to be addressed in order to manage the public's expectations properly.
That's great, yeah, because I do think that building trust is absolutely critical, and at a local level, that's something that it can be really quite powerful. I suppose a kind of final question there as well, and I don't know whether this is something that you would want to comment on, but we were talking earlier on about dropping NHS Lanarkshire levels of satisfaction, and I'm wondering if this is a symptom impact at least there. And if there are any thoughts on whether maybe the digital front door app that's due to be piloted in the NHS Lanarkshire might be something that's helpful, might make an impact, and any thoughts you might have around that?
So I think it's a welcome development in terms of improving access and providing clarity. I suppose what perhaps maybe I'm cautious about drawing any conclusions until seeing some of the evaluation or evidence. In the same way, discussing Mr Simpson earlier, again, equally cautious about drawing a direct correlation between satisfaction levels and number of patients per head of GP in which NHS Lanarkshire also features. At the risk of repeating myself, I think it's about investment in technology and data needs to be accompanied by good evaluation arrangements, so that decision making by health boards, Scottish Government, that they're on the right track, or if they need to change tact, is a part of the implementation of new approaches, whether it's the contract generally or digital front door. But one certainly very keen to see how that evolves.
That's great. Thank you.
Thanks, Stephanie. Thank you very much indeed for those questions. Can I turn finally then to the Deputy Convener, Jamie Green, for a final round of questions? Jamie.
Thank you, Convener. How long would you like me to go on? Because I've got lots of questions.
Well, till 11:30.
Okay, that's grand. Good morning, Auditor General and esteemed colleagues. I've got a few areas to cover. I'm going to start with just going back to an issue that came up earlier around the multidisciplinary teams. It sounds to me like a fairly positive move, the idea that care can be delivered in a GP practice by the person that's best able to offer care, which again goes back to your point about perception of, must speak to a GP, but actually if that can be delivered by someone else, it's better. However, your report seems to allude that some feedback or some of your research has uncovered some dissatisfaction amongst the GP fraternity, in the sense that they actually think it might be adding to their workload, not reducing it. Could you just explain that to me?
Yeah, like you, Deputy Convener, I thought that looked something of a standout comment from GPs as part of the survey about the fact that some GPs felt that multidisciplinary teams had increased their workload, and in some cases with GPs needing to spend more time supervising and training multidisciplinary teams. I think beyond that, it's difficult to draw any definitive conclusions about the extent to which that is a feature across the country or isolated to particular practices. But maybe it's symptomatic of the impact of the investment in multidisciplinary teams not being carried through yet as intended. So this was an approach that was really at its heart to ease some of that pressure on GPs. That hasn't yet been implemented. I can well understand why there might be tensions about how successful that approach has been. Whether it's a teething issue, a kind of mid-implementation phase, or if there's something more fundamental, we probably don't have enough evidence. But I think it's there. I think there's a degree of concern for the government and for GPs and their representatives just to take stock about where they go next with the full implementation of the remaining parts of the role that MDTs were to play. Right.
Do you think the tension is actually that the government are putting money into health MDT personnel rather than increasing the money going through the GMS contracts direct to GPs? Do you think that's do you think the GPs actually just want the money directly to do the work that they've got to do, rather than see people coming in at more junior levels being funded differently, and that money could be going, it's the same pot of cash overall, but is that where the tension really lies, given that they're private practices?
So I think that's a potential. What I might refer is to Exhibit 4 on, I suppose, the totality of spending. And again, when we look, so the investment in GPs so increased by just over 1 billion, 33% in cash terms since 2017-18, and just below 7% in real terms, taking into account inflation. So we've seen a significant investment in GP services. In more recent years, slightly below the rate of inflation. But I think what we're seeing, and I think as Mr Simpson mentioned earlier, some of the communication from GPs and their representatives is what seems to an emerging challenge about the relative investment in GP services compared to secondary care settings, and whether that is sufficient to really shift the balance of care, keeping people healthy and out of hospital rather than treating them when they become ill. Alongside that, I thought, again, some of the change in numbers investment. So as we set out in the report, that we're not seeing the progress that the government had hoped to make with additional GP numbers. We do contrast that, though, with a significant increase in the number of hospital doctors over the same time period. So there's a contrasting story in terms of where investment is being made, and the government needs to do both. I absolutely understand that. It's not an immediate transition away from providing secondary services, but there is undoubtedly a tension that the committee have received in correspondence and has been reported about the investment and the outcome and the achievement of those objectives in primary care relative to secondary care.
I mean, that's interesting. Your exhibit 4 points to an overall increase, albeit an under-inflationary increase in the primary care budget. But the BMA have quite stark views on this. As has already been alluded to, their letter calls it a shocking situation. It talks about the erosion of funding, a shortfall of 22.8%, and they say that £290 million will be needed to fill that gap. So their perception of how GPs are funded or not funded properly seems to not marry up with what the government is actually spending on primary practice. And of course, our job, of course, is to audit government spending in that respect. But the feedback from the front line seems to suggest that they're being massively underfunded. I mean, they can't both be correct, presumably.
Very, like you, Deputy Convener, very clear feedback from GP and the representatives about what their ambition would be and what they consider would be necessary to invest for intended outcomes to deliver general practice services, perhaps also to deliver the GMS contract ambitions from 2018. I think goes, if I may, also back to our recommendations in today's report for that level of clarity, transparency of how the Scottish Government wishes to deliver its vision for general practice, about the medium-term funding requirements for the sector. Is there to be a fundamental shift in where NHS spending takes place in Scotland? Will it remain largely, as we've seen in secondary care setting, or is there a plan to move to greater ratio of investment in primary care settings? And we call for that clarity through today's report.
That's very helpful. I mean, statistics are, we've talked a bit about data and perhaps lack of it, but there are things that we do know and have been made clear to us. Particularly, I would like to look at two pieces of data. One is the ratio of GPs per population, and the other is the number of GP practices in Scotland. And please correct me if I'm wrong, but it seems to be my understanding that the number of practices has fallen considerably over the last 10 years, and also the patient per WTE GP ratio, which perhaps we can clarify that for the benefit of people watching, is different to the GP headcount. So in other words, how many patients a GP has on average. Now, the Scottish Government often claim that ratio is smaller in Scotland, therefore you have much easier access to a GP in Scotland than other parts of the UK. However, your analysis seems to suggest that ratio, that WT ratio, has actually decreased over a course of many years by some margin, actually. It used to be 1,500 patients per WTE GP. That's now up to 1,715. So it's no wonder people can't get an appointment at 8 o'clock to see their GP. There are far more people registered with GPs.
I mean, these are the statistics set in the report. Fiona might want to comment, actually, but I think just in terms of the number of GP practices, for example, I think I'm right in saying that I think it's data up to 2021. Fiona, you might have more up-to-date numbers, but we saw a decrease from just over 1,000 in 2011 to 890 practices by 2021. I'll maybe come back in about the correlation point about access, but I'll get Fiona if you want to perhaps just pick up some of the statistics first.
Yeah, I had a look at the most recent data. So if we look at April 2018, just when the contract was starting, there were about 950 practices. As of April this year, there are 887. So we've got 63 fewer than we had at the beginning of the contract.
Is there some consolidation, or is it better to have fewer bigger practices, or I mean, it's quite hard to tell what that number means. On the face of it, it would look like it's poor because it means that there are fewer practices, therefore, much less local access to a GP.
So, practice list sizes per practice have got bigger because there are fewer practices, but the reasons that practices close is not recorded centrally, so we don't know whether it's because someone handed back their contract or because practices merged. So we don't have a sense of why they closed. We just know that there are fewer practices now than there used to be.
I think you're probably right. I don't think it necessarily matters to the public, whether this is a larger practice or a smaller practice, or indeed what the number of patients that are registered. I think probably they're most interested, can they access care and services when they want to access it? And again, I think what's one of the kind of core parts of our audit was to look at not exclusively GP numbers, again, why multidisciplinary team rollout mattered, ultimately, but capacity within the system to provide service. And I think there are indicators that this remains a system under real pressure, and lack of clarity about the route through to easing some of that pressure and resultant patient services under satisfaction.
Can I ask if Audit Scotland did any analysis on C2 practices? In other words, those practices that were private partnerships but who, for whatever reason, decided to hand back their licence to the local health board. There's been it's quite difficult to get numbers, but the numbers that we were able to pull out of the BMA suggest there's been a marked increase in the number of C2 practices, and in certain regions that's more obvious than others. To take, for example, Lothians, Shetland, Tayside and the Highland regions, you're looking at double, treble or even quadruple the number of practices that have been handed back to the local health boards. Has there any work been undertaken as to why that's happening so much now, why the frequency and the volume are increasing?
I think as Fiona mentioned, we haven't done any dedicated analysis on some of those factors. Anecdotally, I think the circumstances that you describe of pressure, sustainability, ability to recruit GPs and some of the funding, as we've mentioned already, about some of the premises responsibilities for some of the practices are factors about why some premises, whether they're common to all of them, we haven't done that detailed assessment yet, Deputy Convener.
One thing we didn't really go into in great detail was satisfaction. You talked a little bit earlier, I think, about the Health and Care Experience Survey. That's Exhibit 5 in your report. I actually found that probably one of the more shocking graphs in your report. Every single metric, when questioned between 2017-18, 6 years later, people are asked the same set of questions, and every single one of those metrics saw a decline in satisfaction. And some of those declines are quite stark, the most being the overall rating of your care experience as good or excellent was at 69%, down 14 percentage points in just 6 years. So that's, 2/3 of people believe that they're getting a good service and the other third don't. That's pretty shocking. Did anything come out of that survey that jumps out at you as being an area of concern?
So I think as we say, so some of the statistics are will be challenging reading for government and health boards. I'd be interested in their sense of whether that's a surprising set of results, given I think what we hear anecdotally of the pressure that exists on the system. And as I think we've touched on already this morning, which we'll come back to some of the factors about Exhibit 3, and there are undoubtedly pressures within the system that might be indicative of people's experience, people managing more longer-term conditions, perhaps waiting for hospital treatment, that might be informing their overall view, but not necessarily indicative of the service they directly receive from that practice. The other thing, maybe just to highlight some of the people's experience also varies by a combination of other elements, whether it's age, whether somebody's living with a disability. People are more dissatisfied with GP services in some of Scotland's more deprived areas than they are in the more affluent parts of the country. So a lot of variation. But I think from today's report, we feel like we're in the midpoint the implementation of a contract. So what we're trying not to do is draw conclusions yet to say that that's how it will be, or indeed that the contract will resolve this, but just that need for clarity about where this contract is going, along with the overall intent for primary care general practice.
Can I ask maybe a more controversial question? Do you think there should be a top-down complete change to the system? In other words, this GMS contract, clearly the BMS and those representing GP practitioners believe that they're not getting paid enough for the work that they do. They believe that their workload is increasing. They're having to take on ever more patients. Patient satisfaction is on the decrease on the other side of the phone. The public aren't happy with the output. Is the whole system broken? I mean, is this private practice model actually working in Scotland?
I will address your question, but I think what we need is a clear plan of how to deliver, how to provide primary care services, GP services, rather than primary care, I should say. And we make that clear recommendation in the report. The independent contractor model has been in existence since the start of the NHS, dating back to the 1940s. It was tested again, just middle of the 2010s, and a clear preference remained from GPs that this was the model to deliver health services. People's views changed, and I have no insight about whether or not that I think GPs themselves would be better placed. But there's enough evidence to suggest that there is pressure in the system, but to make a judgment about that without a contract having been fully implemented might feel premature.
But I mean, if you look at what's happening in the dental sector, which is effectively is a private sector, albeit it's, the NHS is free at the point of use, so we don't have a privatised health service in Scotland. The government would be quite keen, I'm sure, to stress that. But the reality is that a lot of these services are provided through private contracts. So in other words, they are privatised in some way, shape or form. Do you think there's just no political appetite for any sort of sweeping reforms? If you brought the whole of primary care into the NHS boards, for example, and under a single budget, do you think that it's just a kickback from GPs would be so much that change would never be able to happen? Just government could not introduce such a sweeping change. Therefore, the system will just never change. All that will happen is GPs will just ask for more money and to deal with increased demand.
I think it probably risks me straying into policy areas that a matter of for the government to best decide together with GPs and their representatives about how primary care services or GP services will be delivered in Scotland. I think today's report, though, is saying that the contract, as was agreed, hasn't been implemented as planned. Significant gaps, significant steps to get to a system that can be implemented, monitored, evaluated, addressing some of the data, clarity around long-term funding, real view on the ratio of investment in primary care relative to secondary care. These are all part of the complex system-wide issues that need to be considered over and above the specifics of how the model might operate.
Could you talk me through the areas of your report where you look at the government's plans for recruitment and increasing GP numbers? Obviously, a commitment's been made to increase the number of GPs by 800. Initial feedback from the RCGP said that that's nowhere near enough. In fact, by 2027, they say that even with 800 more GPs, that will leave a deficit of 700. So we're nowhere near where they believe that will be nowhere near what is required. Is 800 a number that's just been plucked out of thin air, do you think? Is that relative to some form of analysis that informs that figure? Is that how many we think we need, or is that just how many they can afford? I mean, the two very different questions, different answers.
Yeah, I think could spread some of that out across myself and Fiona. First of all, Deputy Convener, the 800 was the number that was intended when the contract was agreed, that would be implemented. What we look to set out Exhibit 6 of the report is really the rate of change since 2017. You'll have seen from the key message of the report is that we don't believe that the Scottish Government is on track to meet its 800 additional GPs. This is a question of capacity, though, and I think that there is a risk that in some of the discussion around the 800 target, that it can focus on headcount as opposed to whole-time equivalent. That headcount, as we've already talked about today, can vary depending on, or its impact can vary, I should say, if a GP is working full-time or part-time. As Fiona's mentioned, the number of activity sessions that take place, that's a more fundamental route through to increasing capacity rather than just the number of GPs that headcount that kind of, I think, risk obscuring the intended impact. But if you look at the table and again exclude, and Fiona might want to come on and talk about the role that trainees play, whether they are included or not included in this number, is that Scotland's estimated, and again drawn from survey information, so I won't repeat all of the discussion we've had already, is that on March 24 there were 3,453 GPs, a reduction of 67 in whole-time equivalents from 7 years beforehand. So that progress is looking really constrained. But I think it's symptomatic of kind of the wider position we are in the contract rollout at the moment, is that capacity will come, yes, from GPs and increasing number through trainees, the implementation also of the multidisciplinary teams, about that wider system of practice provision. But at its heart, we don't see, from the evidence that we have, that the 800 target is on track and now unlikely to be met, is our view. But again, I'll bring Fiona in to say a bit more.
Okay, so your question about whether that 800 was just plucked out of the air, there's a really useful letter from 2019 that was sent by the then Cabinet Secretary to the Health and Sports Committee that laid out how that 800 was arrived at. So what they did is they looked at the number of GPs at the time, they looked at churn, you know, how many were likely to join or leave, they looked at demographics, and then they concluded that if nothing was done, GP numbers would probably stay broadly stable in terms of headcount and whole-time equivalent until 2027. So they realised that they would need to increase those because they looked at population change. They estimated that you would need to increase GPs by about 1% every year to meet that demand. And that gave a figure of about 450 more GPs would be required. And then they looked at the vacancy rate and they thought that there was an extra 250 that they were below capacity, so that gave 700. So, and they say very clearly in that letter as well that it's about increasing capacity, not just headcount. In fact, they thought that that 700 would equate to an extra 570 whole-time equivalent. So they took that 700 and then they said as a stretch target, let's make it an 800 headcount. So, but part of what was supposed to happen was they said that there would need to be a constant monitoring and review of that to make sure that it was having the desired effect. So, but no formal review points were put in place. So we've now arrived at a point where, although headcount has gone up, it hasn't gone up as much as expected, but the estimated, I do stress, estimated whole-time equivalent has actually gone down. So that the goal of the commitment to increase capacity does not look to have been achieved. And just to touch on what Stephen said about trainees yet, so we have set out in terms of headcount how many more of those GPs are fully qualified GPs and how many are trainees. So we tend to not always include specialist trainees in our headline figures because trainees don't spend all their time in general practice. They spend about 18 months in hospital posts and 18 months there, so they're not always there. So what we see in the figures is a snapshot of who was there at that time. And then there's also no guarantee that those trainees will go on and work as fully qualified GPs in Scotland.
A good example of that, where this government had a strategy, is the ScotGem project to try and recruit rural GPs. And I was reading a news report recently about that, and there were 52 graduates one year, of which only 10 went on to become GPs, and of which only 2 went to the north of Scotland to actually fulfil GP vacancies in rural areas. So, I mean, that's a drop in the ocean compared to what's required in rural and island communities, where generally there are huge issues in recruiting and retaining or attracting GPs. And despite the incentives, golden handshakes, fast-track schemes and specialist medical training programmes, 4-year programmes to get GPs into rural areas with specific rural medical training, still can't fill those gaps. I mean, those regional inequalities are surely exacerbated as a result of that.
Yeah, I think it's probably illustrative of the point you were making earlier about GP contractors considering, in some of those examples, the sustainability of practices if they're unable to recruit to deliver a safe, ultimately it's about a safe clinical practice, notwithstanding some of the financial issues that have been touched on already.
I guess my final one is on GP nurses, which we don't have a huge amount of time to look at, but there's no specific target or commitment to increase them. But if you're looking at an MDT type model, or one where care can be provided at primary care by nurses rather than GPs to make sure it's easier and quicker to get an appointment, certainly there's some good examples of that where that's working well, but that also includes increasing the number, presumably, of GP nurses as well. Now, my understanding is that that number has decreased in recent years, not increased. However, I'll maybe, or it's flatlined, I think actually your report says, but we'll check that. But in any case, there's no clear target to increase. If you can't hit the 800 increases in GP numbers, the Royal College of General Practitioners and the BMA say that should be 1,500 anyway, but it's going in the wrong direction. That's a worry. Not increasing GP nurse numbers is a worry. Who on earth is going to deliver all this increased demand, is the question, I suppose.
I think I would add, just briefly, in terms of the role that wider members of the GP team play, that clarity, yes, in terms of the rollout of multidisciplinary teams, but the point you mentioned about GP nurses, and much of that we kind of set out in the report, perhaps the thing of note is just some of the demographic factors around GP nurses, about the age profile of many of those members of the team at the latter stages of their career, perhaps. So all of that will have to be factored into in terms of training, recruitment, sustainability. And as you mentioned, there's no commitment to increase GP numbers. But I think stepping back, just that clear sense now of who's going to provide those services through a clear delivery plan to provide that clarity to GPs and the public.
Okay, thank you, Auditor General. Thank you, Fiona.
Okay, thank you very much indeed. And on that note, I'm going to draw the public part of this morning's session to a close. Can I take the opportunity, before I do that, though, to thank our witnesses this morning. Eva Thomas-Tudor, who joined us online. Thank you. Fiona Lees, Carol Calder, and of course Auditor General to you. You've given us quite a lot of food for thought, and we'll need to consider whether there are other people that we would like to quiz about some of the recommendations and outcomes of this very important report that we've been discussing this morning. So can I thank you again, and I will now move this morning's committee into private session.